Hello and welcome to this Learning Disability Awareness session. My name is Melissa Perry and I'm a community learning disability nurse based on a team in Trafford, which is within Greater Manchester. I'm employed by Cheshire and Wirral NHS Partnership Trust. We were very kindly invited to put together a session for St Anne's Hospice to mark Learning Disability Awareness Week, which runs from the 14th to the 20th of June 2021. In terms of the content of the session, I'm going to briefly define what's meant by the term learning disability and then move on to give an overview of the health needs of people with a learning disability, including looking at some of the health inequalities that they experience. I'll then move on to look at some of the initiatives that are in place to address these health inequalities and that aim to promote good health outcomes for people with learning disabilities. And finally, look at some resources to help or top tips to get the best health outcome. So how many people are there with a learning disability? Well, in the UK, there's about 1.5 million people, with the majority of those living in England. Another way to look at that is to think about that about 2.16% of the general population will have a learning disability. So, what is the definition of a learning disability? A learning disability includes the presence of three things. Firstly, the person would have a significantly reduced ability to understand new or complex information or to learn new skills. Alongside that, they would also have a reduced ability to cope independently, which will have started before adulthood and have a lasting effect on development. It's really important to remember that each person with a learning disability is an individual with their own strengths, abilities, support needs, and life story. Some people find it helpful to think of learning disability on a continuum, ranging from people with mild learning disabilities right through to individuals who have severe, profound, and multiple disabilities. People with a mild learning disability may, for example, be able to live independently and be able to cope well with most everyday tasks, but might need some help with areas like budgeting or planning. On the other end of the spectrum are individuals with severe or profound learning disabilities who may require 24-hour care and support in areas such as mobility, personal care, and communication. It's really important when supporting anybody with a learning disability to use a person-centred approach. Causes of learning disability. A learning disability occurs when the brain is still developing, so before, during, or soon after birth. Sometimes the specific cause of a learning disability is unknown, but there are several things that can cause a learning disability. For example, an inherited condition like Fragile X, chromosomal abnormalities, e.g., Down syndrome, complications during birth, resulting in lack of oxygen to the brain, or a very premature birth, fetal alcohol syndrome, or a debilitating illness or injury in early childhood that affects the brain development. We'll now move on to look in a little bit more detail about health. So what we do know from numerous reports over the years is that people with learning disability have poorer health than the general population, and that includes both poorer physical health and poorer mental health. We know that people are far more likely to die prematurely of avoidable causes. In fact, one study shows that people with a learning disability are 3 times more likely to die from an avoidable cause than somebody within the general population. We know that people also can have different patterns of mortality and morbidity, that they can also have multiple health conditions, making it more difficult to manage in a community setting, and that people are far more likely to experience barriers to the healthcare and experience health. When looking at health inequalities and learning disabilities, it's important to take into account the findings from the confidential inquiry into the premature deaths of people with learning disabilities that was completed in 2013. This inquiry was tasked with investigating the avoidable or premature deaths of people with learning disabilities through a series of retrospective reviews of deaths. The aim was to review the patterns of care that people received in the period leading up to their deaths, to identify any errors or omissions contributing to these deaths, and it also did look to illustrate any evidence of good practice and to provide improved evidence on avoiding premature deaths. Of the 247 deaths reviewed, 42% were assessed as being premature or unavoidable, 22% were under the age of 50 when they died, and an average age of death in the learning disability population was much younger than in the general population. So the median age of death in males with a learning disability was 65 years, as opposed to 78 years for the general population. And the average age of death for women with a learning disability was 63 years, as opposed to 83 years. The most common reasons for deaths being assessed as premature were delays or problems with diagnosis or treatment, and problems with identifying needs and providing appropriate care in response to changing needs. Most frequently, these difficulties appeared to occur at the point of investigating, diagnosing, or treating illness, not in identifying that a person was. The overall findings from the inquiry was that the quality and effectiveness of health and social care for people with learning disabilities was deficient. Problems included fragmented services and poor communication between agencies, lack of understanding of the needs of people with learning disabilities, negative attitudes and unhelpful assumptions, failure to make reasonable adjustments, and poor compliance with the Mental Capacity Act. The inquiry went on to make 18 key recommendations. I'm not going to go through each of these recommendations today, but I will just mention one of them, which is that the recommendation to set up a learning disability mortality review programme, more commonly known as the LEADER programme. The Learning Disability Mortality Review, or LEADER programme, was established in 2015 to support local areas across England to review the deaths of people with a learning disability, to learn from those deaths and to put that learning into practice. The fourth annual report of the LEADER programme was published in May 2019, and the programme now provides the largest body of evidence on deaths of people with learning disability at an individual level anywhere in the world. The LEADER programme uses the information and learning gained from the completed reviews to develop national recommendations and to influence policy development. When thinking about health, it's important to be aware that whilst people with learning disabilities can and do experience the same health conditions as the general population, they are also more likely to have certain health conditions, and the pattern of mortality and morbidity in this population can be different. It's not possible to go through each of these health conditions during this presentation, so I will just pick out a few as an example. Respiratory disease is the leading cause of immediate death in the learning disability population, and there's an increased risk of chest infections in people with learning disabilities, which are secondary to dysphagia. Cardiovascular disease is the second commonest cause of premature death, and it's found to be as common in the population of adults with learning disabilities when compared to the general population, and is experienced at epilepsy. Approximately 1 in 3 people with a learning disability has epilepsy, which is compared to 1 in 100 of the general population, and it's the most common comorbid health condition experienced by people with learning disabilities. The presentation of epilepsy is often more complex, with multiple seizures and polypharmacy when compared to the non-learning disabled population. Interestingly, the pattern of cancer is also different within the learning disability population, with gastrointestinal cancers being more prevalent, which includes esophageal, stomach and gallbladder cancers. When considering mental health, up to 40% of people with learning disabilities experience mental health difficulties. Anxiety disorders, depression and schizophrenia are among the more common. Accurate diagnosis can be difficult to make due to, for example, communication difficulties, physical health and diagnostic overshadowing. And having one psychiatric disorder seems to be a risk factor for more psychiatric disorders amongst people with learning disabilities. There's also an initiative called STOMP, which stands for Stopping the Over-Medication of People with a Learning Disability and Autism, which is a national programme looking at optimising the use of this type of medication. Given that we know that people experience health inequalities and barriers to health services, what can we actually do to improve the health outcomes for people with a learning disability? Well, one thing that can be put in place is reasonable adjustments. Reasonable adjustments are the changes that the law says that people or services must make so that disabled people can use services as easily as everybody else. Reasonable adjustments can mean alterations to buildings, so for example by providing lifts, wide doors or ramps, but it also may mean changes to policies, procedures and staff training to ensure that services work equally well for people with learning disabilities. Putting these reasonable adjustments in place can help people get better healthcare and live longer. When thinking about reasonable adjustments, it's helpful to think of the acronym TEACH, which stands for Time, Environment, Attitude, Communication and Help. Time, so for example, some people might need a longer appointment, or they might need an earlier morning appointment when the waiting room is quieter if they're not able to cope with a busy environment. Environment, so this could mean, for example, doing a home visit rather than expecting somebody to come into a clinical setting if that's something that they struggle with. Attitude is about treating everybody with dignity and respect and as an individual and using a person-centred approach. Communication, this may mean using accessible information, so for example easy read leaflets or pictures. And help, this is about listening to others, so families and carers, people who know the individual best, and obviously listening to the individual themselves. It's also about knowing when and how to get specialist help when needed, so for example for the specialist learning disability team or hospital liaison nurse. To help highlight reasonable adjustments, I'll share with you Angela's story. Angela has a learning disability, autism and a significant hearing impairment. She understands some basic sign language but has limited verbal communication. Angela has very rigid daily routines and she can easily become stuck in these routines, which can make it difficult for her to move on to the next task or activity. She lives in 24-hour supported living and is supported by carers, some of whom have known her for over 10 years, so they know Angela well. Angela needs to attend hospital for an appointment as she's experienced unexplained weight loss and pain. Angela receives a hospital appointment asking her to attend at 9 a.m. Her carers decide to meet to go through what reasonable adjustments Angela will need to be able to attend the appointment using the TEACH approach to think about these, and they agree the following plan. Time. Angela will struggle with the 9 a.m. appointment as it's right in the middle of her morning routines. Carers think that an appointment after lunch will work much better because it will give her time to have moved through her routines and she'll be ready to leave the house for her appointment. Environment. Angela will struggle waiting in a noisy, unfamiliar environment such as a hospital waiting room. Carers contact the hospital and ask if there's a quiet area that Angela can wait in before her appointment. They also ask that any rooms that Angela is going to enter are as clear as possible from any leaflets, as she can find these quite distracting and become fixated upon them. Attitude. All involved use a person-centred approach, thinking and looking at what is going to work best for Angela. For example, her care staff know that using an iPad helps to reduce her anxieties, so part of the plan is to take this along with them to the hospital appointment. Communication. It's really important that all involved are fully aware of Angela's needs and prepared for the appointment. Her carers share a copy of Angela's hospital passport with the hospital. It includes important information about Angela, such as what she likes and dislikes and how best to communicate with her. Help. Carers who know Angela best are going to support her to the appointment. They've also enlisted the help of the Learning Disability Hospital Liaison Nurse, who helps to put the reasonable adjustments in place at the hospital. With these reasonable adjustments in place, Angela is able to attend her hospital appointment and it is a positive experience. I'm just going to talk briefly about hospital passports. A hospital passport provides important information about a person with a learning disability, including personal details, type of medication they're taking and any pre-existing health conditions. It also includes important information about how a person communicates and their likes and dislikes, which can be very important when they're first admitted into a hospital. Hospital passports allow health staff to understand the needs of the individual and to help them make the necessary reasonable adjustments to the care and treatment they provide. Hospital staff find these documents a valuable resource. Another health improvement initiative for people with learning disabilities is the Learning Disability Annual Health Check. These annual health checks are for adults and young people aged 14 years and over who have a learning disability. They are completed by the GP or GP practice nurse and include a review of physical and mental health with an improved health experience for patients, families and carers. The health check is designed to review known comorbid chronic conditions such as epilepsy, dementia and diabetes, and it is an opportunity to identify a wide range of potential unmet health needs which may otherwise go unreported or unrecognised without such a proactive screen. The annual health check is also an opportunity to develop a personalised health action plan with patients and carers that can be shared with appropriate relevant support. And it's important when supporting anybody with a learning disability to think about communication. Studies show that about 90% of people have some form of communication impairment. So here's some tips around how to communicate best. Remember how it feels to not understand. Ask carers and family if the person has a communication passport and involve the person as much as possible in all communication. Use gestures and pictures to back up what you're saying and make sure that you have the person's attention before you start. Try to use everyday words, but be aware that your everyday words may not be the individual's everyday words. And keep your sentences short with only one or two key words or ideas. It's important to give plenty of time to process information and try to use closed questions. Look out for signs that the person may have understood. So we've come to the end of this session. I'm just going to finish with some top tips for meeting the health needs of people with learning disabilities. Firstly, know the statistics around health inequalities and understand the reasons for them. Secondly, consider appointment times and reasons for people who did not attend their appointments. Explore this further. Number 3, find out how the person best communicates. Number 4, read and use the person's hospital passport. Number 5, know that reasonable adjustments make a big difference. Number 6, remember to see the person and not just their learning disability, so please avoid diagnostic overshadowing. Number 7, build a relationship with your local learning disability liaison and community nursing team. Number 8, become a learning disability champion for your practice or service. Number 9, allow the person to be the expert about how they feel. And number 10, look at implementing the NHS